synapse. Let us understand how to place lesions in the central nervous system. The operative structure of the central nervous system is similar to an electrical circuit, the brain being the power source, the tracts acting as the wires, and the effectors representing the electrical device. Physicians often compare central nervous system lesions to mathematics. This is true because placing the lesions is as simple as arithmetic. A clinician should be able to explain the symptoms and signs of a patient by a single lesion or by as few separate lesions as possible. This is called as the principle of Occam's razor. This is also called as the KISS principle. KISS, standing for keep it simple, not stupid. Let us now delineate what lesions we can expect to see in the central nervous system. From above downwards, we can find cortical lesions, lesions in the internal capsule, thalamus, lesions of the internal structures of the brain, lesions of the midbrain, pons and medulla which form the brainstem, lesions of the long tracts of the spinal cord, lesions of the nerve roots called as radiculopathies, lesions of the peripheral nerves called neuropathies, neuromuscular junction disorders, and finally muscle lesions or myopathies. A thorough history and skillful examination is more than enough to delineate lesions of the central nervous system. A thorough history must include details of the motor symptoms like weakness, paralysis, loss of power, incoordination, stiffness, involuntary movements, gait disturbances, etc. Sensory symptoms in the form of positive phenomena like numbness, tingling, pain, etc. Negative phenomena in the form of loss of sensation or altered sensations. Bowel and bladder disturbances in the form of hesitancy, urgency, precipitancy, etc. Symptoms of cranial nerve dysfunction ranging from anosmia to dysarthria. Mental symptoms, speech disturbances, consciousness levels, seizures, and many more. Additional history to elicit the cause of the lesions like signs of raised intracranial tension, neck stiffness, fever, trauma, contributing factors, alcohol, vaccinations, etc. can provide us with sound information to place the lesion. A thorough examination of the functioning of the central nervous system in the pattern given below has to be performed. Assessing higher mental functions tells us the status of the cortex. Cranial nerve examination can place the level of the lesion at the brainstem. Motor system examination helps us place the type of lesion and the approximate level of the lesion. Sensory examination will give an almost accurate sight of the lesion. Added signs of cerebellar lesions can give us a sure-shot diagnosis. Gait disturbances can be a part of a manifestation of a single lesion. Meningeal signs can indicate local pathology. Relevant systemic examination can provide the etiological clue to diagnosis. To understand the lesions, we need a sound knowledge of tracts. Three vital tracts are to be remembered here. The motor tract, also called as the pyramidal tract. This tract starts in the area 4 of the motor cortex in the precentral gyrus. The homunculus provided in the picture here gives us an idea as to which part of the cortex gives rise to neurons supplying which part of the body. The axons of the neurons present in the cerebral cortex descend along the corona radiata to converge on and enter the internal capsule. In the internal capsule, these fibers lie in the posterior limb. It further descends down to enter the crux cerebri of the midbrain. It occupies the middle 3/5 of the cerebral peduncle in the midbrain on each side. The tracts further descend down to lie in the ventral pons, where they are surrounded by pontine nuclei. From here, they are continuous as the pyramids in the ventral medulla. In the lower medulla, 80% of these fibers cross to the opposite side. This is called as the motor decussation of the pyramids. Post-decussation, they form the lateral corticospinal tracts. These tracts descend down in the white matter of the spinal cord as the lateral corticospinal tract. At various spinal cord levels, the fibers synapse with the internuncial neurons which enter the grey matter to end in the anterior horn cell. The axons of the anterior horn cell leaves the cord via the ventral spinal root to meet the dorsal root and form the peripheral nerve. The peripheral nerve finally supplies the organ. The uncrossed fibers continue as the anterior corticospinal tract in the spinal cord and end at around the mid-thoracic level. The fibers from this tract cross at the specific levels of the spinal cord to join the anterior horn cell. An important concept to understand in this tract is the presence of the anterior horn cell. The anterior horn cell marks the junction of the upper motor neuron and the lower motor neuron. The nerve fibers up to the corticospinal tract act as the upper motor neurons, and anything starting from the anterior horn cell is the lower motor neuron. One can notice that the nerves supplying the cranial nerve nuclei cross the midline at specific levels of the brainstem to supply the nuclei. These are called as the corticobulbar fibers. The third and fourth cranial nerves arise from the midbrain, the fifth, sixth, seventh and eighth from the pons, and the terminal nerves 9th, 10th, 11th and 12th from the medulla. Other descending tracts of the spinal cord include the rubrospinal, tectospinal, vestibulospinal, reticulospinal and olivospinal tracts. They are collectively called as the extrapyramidal tracts. Next, we shall understand the sensory tracts. The sensory tracts we need to understand are two. The sensory tracts start at the peripheral receptors distributed along various dermatomes as shown in the picture. The dermatomal distribution is very important to place the sensory level of the lesion. Here, a rule of 3 can be understood. The C3 supplies the neck, the T3 supplies the axilla, the L3 supplies the knee, and the S3 supplies the perianal region. The receptors present in this region are specialized endings of axons of neurons lying in the dorsal root ganglion. The dorsal root ganglion contains bipolar neurons, whose second axon retraces to the spinal cord to reach the two tracts. The first tract is the posterior column tract, which itself is made up of two tracts, the fasciculus gracilis and the fasciculus cuneatus. These tracts descend along the posterior column, which is marked in blue, up to the medulla. As they ascend, they receive neurons from various levels of the cord. At the level of the medulla, they reach the nucleus gracilis and nucleus fasciculus. The fibers from these nuclei cross along the internal acute fibers to form the sensory decussation. Post-decussation, they form the medial lemniscus. The medial lemniscus ascends along the areas of the brainstem as shown in the pictures and finally reaches the ventro-posterolateral nucleus of the thalamus. From here, they are related to the sensory cortex of the brain via the internal capsule partly and the corona radiata at the specific coronal level. The sensory cortex is present at the postcentral gyrus. The posterior columns are known to carry touch, pressure, cortical sensations like tactile localization, tactile discrimination, stereognosis, proprioception and vibration sense. The second tract that we need to talk about is the spinothalamic tract, which is marked in green. Their origin is same as that of the posterior column. These fibers cross at the level of entry into the spinal cord and reach two separate tracts that are almost continuous with each other. These are the ventral and lateral spinothalamic tracts. The tracts ascend along the spinal cord, receiving fibers from the opposite side, and they finally reach the medulla. At the medulla, they separate, and these tracts form the ipsilateral spinal lemniscus, which is placed in close approximation to the medial lemniscus. The fibers ascend along the tract at various levels of the brainstem to reach the ventro-posterolateral nucleus of the thalamus. From here, they relate to the sensory cortex similar to that of the posterior column. The ventral tract is known to carry sensations of crude touch and pressure, while the lateral tract is postulated to carry pain and temperature sensation. With this, let us now learn about placing lesions. At the end of the neurological examination, one must be able to interpret the clinical signs and deduce whether the lesion being dealt is a pyramidal, extrapyramidal or a cerebellar lesion. one must also detect whether it is a upper motor neuron type of lesion or a lower motor neuron type of lesion. Let us begin with the motor lesions. The various diagnoses that we can make are monoplegia, hemiplegia, quadriparesis with the face affected on both sides, crossed hemiplegia, quadriplegia with sparing of the face, bibrachial paralysis or crural diplegia, paraplegia, and sensory involvement. Considering each of these scenarios one by one, let us talk about monoplegia. Now, tracing the fibers of the specific limb that is affected, one can note that the fibers of the arm alone or limb alone can be affected at three areas. At the cortical level, it can be due to a stroke or a cerebral palsy which can affect a single area. Note that the lesion may be associated with cerebral hemispheric signs. It is an upper motor neuron type of paralysis. At the spinal cord level, the presentation can be that of a one-sided cord compression by a tumor or a one-sided cord lesion as in Brown-Sequard syndrome. It can be identified by the presence of a sensory level that is absent in the cortical lesions. Again, this type of lesion is an upper motor neuron type of lesion. At the level of the peripheral nerves, nerve entrapment or neuritis in the form of mononeuritis multiplex or plexus neuritis can cause monoplegia. If the root happens to be involved, it will cause severe shooting pains in the root distribution called as root pains. These lesions are lower motor neuron type unlike the above two types and will also have typical features of neuritis, and hence it can be differentiated from the other two. The next type of lesion we shall talk about is a hemiplegia. This is the most commonest presentation that one will be encountering in clinical practice. We have to look for an area where fibers supplying such a large area of the body are found together to be affected at once. Hemiplegias can be of cortical origin. A right-sided lesion of the cortex will produce a left-sided weakness or paralysis. These cortical lesions are usually less dense owing to the fact that the area involved is large, which is unlikely. However, the signs of cortical involvement are observed. Dominant hemisphere lesions leads to aphasia, apraxia, etc. Lesions have hemiattention, sensory extinction, spatial disorientation, etc. In addition to these lesions, one can also have cortical sensory loss, horizontal eye deviation to the side of the lesion, and homonymous hemianopia. The next type of lesion producing a hemiplegia is the lesion at the internal capsule. We know that the fibers from all areas of the cortex converge to form the internal capsule. Any lesion at the internal capsule produces a dense hemiplegia because all the fibers converge and a large area is involved with even small lesions. There is no cortical symptoms and no sensory symptoms in this condition. This is a typical feature of internal capsule lesions. Lesions of the brainstem can also produce a hemiplegia but have a typical presentation and they will be dealt later. Lesions at the high cervical cord before all the neurons leave the spinal cord can also produce hemiplegia. This, however, will show a typical feature of Brown-Sequard syndrome. The Brown-Sequard syndrome type of distribution confirms the cord lesion. There are umpteen pathologies like bleeds, tumors, strokes, syndromes, etc. which can cause hemiplegia. They can be identified by associated symptoms. For example, subarachnoid bleeds will show raised intracranial tension. Similarly, all the presentations will have typical features to suggest their etiology. Next, a finding of quadriparesis with the face involved on both sides can be of two types. The face involvement can be an upper motor neuron type where the corticobulbar fibers are involved. With this type of presentation, the lesion is present in the internal capsule or in the cortex. The patient will have bilateral cortical lesion or bilateral internal capsule lesion, and hence he or she assumes a decorticate posture. The face involvement can be of lower motor neuron type because of a bilateral brainstem injury. In such cases, the specific signs that can be seen depend on the level of the lesion. Midbrain lesions will have coma and poor responses of the pupil owing to the fact that the third and fourth nerves arise from the midbrain. Pontine lesions will cause something called as Loughnane syndrome. Medullary lesions will cause upper face to be spared and only the lower cranial nerves are affected, leading to dysphagia, inability to move the neck, etc. A decerebrate posture is attained by the patient in cases of these brainstem injuries. Causes can be hemorrhages, infections, tumors, strokes, trauma, and many more. A typical type of weakness that we happen to notice in brainstem lesions is called as the crossed hemiplegia. The crossed hemiplegia occurs because the corticobulbar tracts cross at their specific levels in the brainstem to supply the cranial nerve nuclei, and any lesion before it crosses will produce an upper motor neuron type of lesion. However, any lesion once the nerve crosses produces a low motor neuron type of lesion. The low motor neuron lesion at the levels will cause ipsilateral cranial nerve deficit with contralateral paralysis. This is the hallmark presentation of a brainstem lesion. According to which cranial nerves are involved, various syndromes have been described. Weber's syndrome, Millard-Gubler syndrome, etc. are some examples. The causes can be strokes, bleeds and tumors, and many other causes can be incriminated for the formation of crossed hemiplegia. Next, we shall talk about a quadriplegia. This is a condition where you notice that the face is spared and the limbs and the body is affected. The lesion is necessarily below the origin of the cranial nerves because the face is obviously spared. So, the lesion is below the medulla. The lesion has affected all the four limbs and therefore the lesion has to be above the level of the brachial plexus. So, high cervical lesions can cause quadriplegia. They have no cerebral or cranial nerve signs, but the sensory signs depending on the involvement of the region are present. Mid-cervical lesions can also give rise to this condition, but they usually spare the shoulders. These lesions can be due to transverse myelitis, trauma, etc. A specific type of disease where the peripheral nerve is affected and even then causes quadriparesis is called the acute inflammatory demyelinating polyradiculopathy. The prototype of this condition is the Guillain-Barré syndrome or GB syndrome, which we will study about later. Next, we shall look at a scenario of bibrachial paralysis or crural diplegia. It can occur due to cerebral causes where the pre-Rolandic area is involved bilaterally. The most common example for a crural diplegia is a cerebral palsy. The diplegia here is of upper motor neuron type. Diplegia of lower motor neuron type can be found in cervical lesions where bilaterally the brachial plexus is affected or when anterior horn cells of the cervical area are affected. These are, however, theoretical possibilities. The next scenario is a paraplegia. The origin of a paraplegia can be noted in cerebral cases also, where a stroke affects the A2 segment of both the sides with an atretic A1 on one side, or midline meningiomas, sagittal sinus thrombosis, etc. can also cause the same presentation. This happens because the leg areas of both sides are placed close to each other in the cortex. In such cases, there are signs of cortical involvement and signs of an associated disease. This lesion will always be of the upper motor neuron type. Thoracic level spinal cord contains the fiber supplying the lower limb only. Hence, this area can produce a paraplegia with a sensory level that can be elicited with sensory examination. Also, the lesion at the thoracic level will be of an upper motor neuron type. Paraplegia can also be a low motor neuron type of paraplegia. Lesions of the cord at lumbar levels will lead to lower motor neuron type of paraplegia. The sensory level will also guide the diagnosis. Bowel and bladder involvement becomes more profound in the lower motor neuron type of lesion. Concluding the localization of motor lesions, one can say that spinal cord lesions produce quadriplegia and paraplegia, brainstem lesions cause crossed hemiplegia, internal capsule lesions will cause hemiplegia, and a cortical lesion can lead to monoplegia, hemiplegia, or even paraplegia. The chart given in this page summarizes the discussion so far. Next, we shall speak about sensory involvement. The level of a sensory lesion can be detected as per the dermatomal distribution. Type of sensory symptom will also give the detail as to which tract is involved. Loss of position and vibration sense is due to a dorsal column lesion, whereas loss of pain and temperature sensation indicates spinal thalamic tract involvement. In the sensory system, the cortex is not considered as the highest level. It is considered as the center for the cortical sensations. The highest point is considered to be the thalamus. The thalamic lesions will produce opposite-sided loss of sensation of all types, whereas a lateral medullary lesion produces the same type of loss like that of a crossed hemiplegia. Transverse cord lesions will cause loss of sensation below the level of the lesion. The zone of lesion in all these cases can be indicated by the level of paresthesia. Brown-Sequard syndrome is a type of presentation seen in hemisection of the cord when there is loss of pain and temperature sense on the opposite side of the lesion and loss of cortical sensation as well as touch and pressure sensation on the same side of the lesion. Radiculopathies are typical in their presentation, having root pains and involvement of the specific root. The sensory level of the pain or the sensory symptom will point to the diagnosis. Peripheral nerve lesions or sensory root lesions will cause a typical glove and stocking type of sensory loss. History and examination can differentiate between pyramidal and extrapyramidal tract lesions. Extrapyramidal tract lesions should be dealt with syndromically, for example, Parkinson's disease, Corias, etc. Positive cerebellar signs need a thorough examination of the cerebellar system. Thank you.